Me here for having me here to discuss about managing ADC hematogenetic. These are my disclosures. And this is a kind of summary of what we're going to discuss today. We're going to review toxicity profile of ADC, especially with regard of nausea and vomiting side effects, discuss which are the risk factors related to emesis and how national, international guidelines address this topic with regard of ADC, and then to run together a clinical case just to get practical feel of how patients get managed in the clinic. Of course, ADC structure we all are familiar with. You have an antibody which is directed against a specific tumor cell antigen and linked to the antibody through a linker, which may be cleavable or not cleavable. You have a cytotoxic drug. Cytotoxic drug changes according to the type of ADC we are actually using and is the drug that is actually killing the cancer cell. Few ADCs have been developed so far. The very first generation, should I start? Yes. The very first generation of ADC are the ones that were kind of linked to a tubulin inhibitor payloads. They all have a tubulin inhibitor as a payload drug, which is the chemotherapy drug led to the antibody. And they have different targets, as you can see here. Then you have the new generation of ADCs, which are the ones who are actually running in the clinic, especially in the breast cancer area, which have a cleavable linker and the payload is consistent with the DNA interactive payload, which means that they actually either work with DNA intercalation, or they kind of block the tubulin formation. And these drugs are actually the deruxtecan and sacituzumab, which we mostly use in the clinic. A few ADC are up to come, and they're both in late stage of development or early stage of development. And the carbazine or the potecan are two of the most advanced one in the clinical trials. So we'll see them soon in our practice. And that's why probably focusing now on the way to manage these initial ADCs we are kind of getting practice in the clinical practice is important because efficacy results are very critical. So how do they work? It depends on the type of payload they have and whether it's actually permeable to the baseline, to the cell membrane or not. We do have two different mechanisms of action. One with no byostandard effects. Actually, the antibody, the ADC binds to the antigen, gets into the cell, and in the lysosome, the payload is delivered, and it kills the cancer cell by tubulin blockage. This is what we see, and we have seen so far with TDM1. And then we have the new generation of ADC, where the payload is actually permeable to the membrane and can get out of the cell once it is internalized. And this is a probably explanation of the byostandard effects, because actually the drug gets into the cancer cells that have the antigen on their surface, get inside, the payload is actually delivered into the cell, and then is free to get out of the cell in the stromal tumor to get activity not only on the cells that have the antigen expressed, but also on the other tissue. This is probably the reason why these drugs are very active and are more active than the very early developed ADC, because they can get they can get rid of tumor heterogeneity, working in the cells that express the antigen and in the cells that don't. But this may also account of the different safety profile we are seeing in the clinic with these new ADCs. And eventually the toxicity we're observing is a kind of unique, is linked to the cytotoxic payload, which we said is not anymore just related to the cancer cell that express the antigen, but with byostandard effects may also get into the tissue that don't express the antigen, kind of making wider the side effects profile. And it's antibody related on a smaller amount, like cardiotoxicity was actually related to the target over 2, which is expressed on the heart tissue. Then we have another category of side effects, which we currently don't explain very well, which is the interstitial lung disease, which is probably related to activation of the immune system or other stuff, which we don't know yet how to explain. And this is a summary on your left of the most frequent side effects we are observing with the ADCs we're currently using in the clinic, mainly TDXD and sacituzumab govitecan. Alopecia, GI toxicity are probably the most frequent side effects we are observing and adverse event we are observing. And then we have hematologic toxicity and specific toxicity like lung disease or hepatic disease. When we look at the way the mechanism of ADC toxicity work, the standard effect and the amount of payload in circulation are probably the two reasons why we see a spectrum of toxicity which is wider than we observed earlier with TDM1, for instance, because as we'll see through the presentation, the trastuzumab deruxtecan and sacituzumab govitecan toxicity is very different from what we saw with TDM1. And it's probably related to these two factors I mentioned earlier. Now, going to analyze all patients treated with ADC in the clinical trials, it's a patient population of around 22,500 patients. Nausea was the most frequent adverse event that was registered any grade, and vomiting was at the place 20 as a most frequent adverse events. The deruxtecan payload agent, TROP2 and HER2, and breast cancer are critical factors to kind of predict the incidence of nausea and vomiting our patients are going to have. And trastuzumab deruxtecan and sacituzumab govitecan, among the different ADCs that were included in this kind of patient meta-analysis, were actually the two drugs which were mostly related to this nausea and vomiting increase. Of course, these are the two probably most used ADC drugs used in this patient population. And this is a nice slide looking at different toxicity profile of different ADCs. We don't see a class effect in this drug. Actually, you do have some ADCs that have peculiar side effects, which are not the same depending on which drug you're looking at. In the first picture, you have the TDM1, and as you can see here, the nausea and vomiting ranges from 20% for vomiting and 30% for nausea, so a very moderate incidence. And if you look at trastuzumab deruxtecan or sacituzumab govitecan, graphically you can see and numerically that the incidence of nausea and the incidence of vomiting is much higher. It's around 80% for deruxtecan and 75% for sacituzumab, and vomiting is about 45%, 50% for both the drugs. So there is a huge increase in these two categories of drugs of these GI side effects, which is not seen in the trastuzumab deoxycholic, where we observe ocular toxicity, which we don't see in other compounds, but we don't have such a high increase of GI toxicity. So not all ADCs are the same, and it very much depends probably on the payload and on the type of antigen that they express. However, this is nausea and vomiting for the drugs we mostly use is a critical side effect. Nausea in TDXD treated patients is around 70% in breast cancer patient population, and in other cancer types, which are gastric and lung, where TDXD has been used, it ranges for 61 to 67% and 26 to 44%. So it really depends also on the type of cancer you're treating. However, rates are quite high, whatever cancer you are actually having. It is important to consider nausea and to ask our patients how nausea is affecting their daily life. Because see, for very low stage, nausea is just a discomfort and oral intake is not a kind of impacted. But when you go to moderate stage of nausea, stage 2, you basically start to have food intake reduction and eventually also fluid intake reduction. Grade 3 is more severe. You stop taking food because it's actually not likable experience to eat. And stage 4, it becomes life-threatening because you're not taking fluids or food. Of course, this stage of nausea is also to kind of being overseen according to patient age, because a grade 2, grade 3 nausea or a grade 2 vomiting may be critical, may be important in a young patient, but may be be critical and life-threatening in a very old patients who gets dehydrated no matter what you do. So with nausea and vomiting may get even worse. So the problems related to nausea and vomiting, which we probably sometimes underestimate, but that actually we must focus on in order to keep on our patients on treatment, is dehydration, loss of appetite, weight loss, which is a critical problem in metastatic cancer patients, where keeping weight is a sign actually of good performance. Impaired quality of life, because people cannot get the same type of life they were getting without our treatment. And very importantly, it may lead to discontinuation of treatment or lack of adherence. Of course, having a patient that is experiencing even low-grade nausea through all the cycle of their treatment may lead patients to think that they don't want to get the treatment anymore. So it's a complication and the side effects that may be needed to be overlooked, even if not of a very high grade and so life-threatening. And these are actually the drugs we're using and the clinical trials where the drug were registered. So we have trastuzumab deruxtecan from the Destiny 0304, the sacituzumab govitecan and TDN1. And this is just to show you the proportion of difference of nausea and vomiting incidents among the different drugs we're actually using in breast cancer. As you can see, we are starting with TDN1, where we had an incident around 40% in of patients getting any grade of nausea and 19% any grade of vomiting. And we are going up to 77% and 50% for the deruxtecan and sacituzumab respectively, and 52% and 19% again for vomiting from deruxtecan and sacituzumab respectively. Rates are different from SYD 985 and dato deruxtecan. As you can see, different nausea incidence is a little bit lower in the TULIP trial for this SYD 985, and also vomiting is a lower incidence, while for the dato deruxtecan, it's a little bit lower than the TDXT, but still quite high compared to the TDN1. And this is the incidence in the sacituzumab govitecan patient population coming from the ASHEN trial. As you can see, there is almost a double incidence of grade 1, grade 2 nausea in patients getting sacituzumab. But usually the onset is around 20 days and the duration is about 3 days per episodes. And this is the trastuzumab deruxtecan. I think this is a critical molecule where the mechanism of action is the one of ADC. The payload is actually permeable to baseline membrane of the cancer cells. So we do have bystander effects in this drug. And so that's why we probably see the side effects we're observing. It is a drug that we are currently using in our clinical practice, and we probably see more and more in our daily activity. In the US is approved for HER2 positive and HER2 low metastatic breast cancer, for metastatic gastric and metastatic non-small cell lung cancer if HER2 mutated. In Europe is approved for HER2 positive and HER2 low breast cancer and gastric cancer if HER2 positive. And in Canada here is approved for HER2 positive and HER2 low metastatic breast cancer. However, as you can see from this slide, area of trastuzumab deruxtecan development in breast cancer is much wider, going from HER2 positive to HER2 low to HER2 ultra low disease, as we'll see this year in ASCO meeting. Therefore, we'll have plenty of patients that will experience this treatment, and therefore we need to take care about the toxicity they may experience. Importantly, because the median PFS in these patients is quite long. So you have treatment that may last for more than a year. And looking at a survey of patients treated with trastuzumab deruxtecan, actually nausea is one of the most, is the first side effects and adverse events that have been recorded for the clinical trials. So the vast majority of patients experience low-grade nausea, which is grade 1, grade 2, and nausea is more than 70% in breast cancer, as ranging from 60 to 67% in gastric and lung cancer trial. But what is important is that the nausea is a very early symptom. It starts when we start the treatment. It's not coming after several cycles of treatment, but it's really a side effect that arise as soon as the people get the infusion of trastuzumab deruxtecan and persists persisted in subsequent cycles. Importantly and differently from what we've seen from other chemotherapy we're used to kind of manage, is that the nausea from T-DXd starts from the very beginning and lasts through all days of treatment. Basically goes from day 1 usually through day 15 or day 20. So it goes well beyond the delayed phase, and we'll see why. Probably that's related to the way the drug is metabolized by the body. So this is, again, those are the clinical trials where the trastuzumab deruxtecan have been tested and led to registration in the different clinical setting. And there is a huge consistency through the trials in the incidence of these adverse events. See, the trials go from 70% to 77% with regard of nausea, and 30 to 50% with regard of vomiting. So you have a quite consistent reporting for these adverse events that is actually a warn for us to kind of manage it correctly when we treat our patients. And these are, again, the rates of nausea and vomiting among the different trials, just to stress out the consistency of the way the side effects happens. So it's a truly effect that is not related to a trial compared to another trial. When does the nausea starts? Usually the median onset of nausea was day 3, and actually for vomiting is a little bit delayed by day 9, day 10, so it's a little bit later. This is surprising because usually the two side effects are often related to. The median the duration of nausea is grade 10, is 10 days, excuse me, and a few patients actually get nausea even later than day 10. It's like they have higher grade of nausea for the very first day, 10 days after the infusion, and then it becomes a grade 1, and this grade 1 nausea comes back lives with the patients till they come for the next cycle infusion. So it's a kind of very bothersome feeling and discomfort for patients. So see, it starts immediately after the very first infusion, and then if you don't treat nausea and vomiting appropriately, actually it reaches a plateau and it doesn't go away through cycles. It's like the patient never get adapted to the drug. They keep on having nausea through the different cycles they get during their therapeutic phase. And again, this is the table with the different grades and the need of getting intervention. And as you can see here, you may start to get an intervention when you have nausea and vomiting from grade 2 and nausea from grade 3. So it's very tiny, the difference in between grades. And I think for a more fragile population, which may be patients treated in the metastatic setting, you need to be very careful also in a grade 2 long-lasting nausea, because it may create problems on the long term. So why this deruxtecan is causing nausea over the very first 10 days from the infusion? It's probably due to the pharmacokinetic of the drugs and the way the drug stays in the body, and the way the unconjugated payload, which is the toxin, stay in the body stream. And see the way nausea and vomiting goes through the cycle, it's almost like the way the drug is metabolized by the body. So this may be a reason why it's we have these long-lasting side effects. And these are the 3 drugs we have experienced in breast cancer. So the TDM1, the TDX6, and the sacituzumab. And gastrointestinal side effects are very common and very much higher than TDM1 in the latest 2 antibodies. And for sacituzumab govitecan, we also have another problem, more than nausea and vomiting, which is diarrhea, which we don't see a lot in the TDXT, but which has a quite high incidence in sacituzumab govitecan treated population. So it's another side effect we need to pay attention to, because together with nausea and vomiting may lead to dehydration of patients and fluid imbalance, which may be lethal, as I told you, in older patients. So which drug we want to have as an antiemetic drug for these patients? These are new compounds. So we're still learning how to manage these new side effects, and we're learning as long as we keep on treating patients. So we need something simple and convenient. We have a PFS that lasts more than 30 months. We are talking about patients treated for 1 year, 2 years or more. So we need something that we can rely on and it's easy on the patient to get. We don't want to get very complicated drugs to treat nausea and vomiting. The drug should be able to optimize nausea control from the very first cycle. And importantly, we should have something that lasts over the very first 5 days from the infusion, because as I showed you, many patients continue to experience low-grade nausea through all the 21 days of the cycle. So we don't get that feeling, because for 1 year or 2 years, getting this nausea grade 1, grade 2 is very uncomfortable. And also there is the need to prevent anticipatory nausea, because anticipatory nausea is the problem that gets the patient not coming anymore to get the therapy straightforward, because obviously is afraid of getting there and getting worse. Why NEPA may be an option with these patients? There are 2 factors about NEPA that are actually make the drug very suitable for these compounds. The very first one is a longer half-life compared to the other antiemetic drugs. So that means they stays longer in the blood and they may work longer, and it may prevent delayed nausea. And the other thing is the percentage of saturation on LK1 receptors, which is higher compared to the other antiemetic drug, offering a kind of higher potency antiemetic effect. Now we have several studies that actually tested the NEPA activity with aprepitant and the 5-HT3 receptor antagonist. And as you can see from the slide, the activity of NEPA lasts for a long time and get rid of nausea and vomiting after day 2 and day 3. So from the period 3-5 days, it still has an activity compared to the aprepitant drug. And there is another study where they checked actually the incidence of nausea and vomiting and the complete response from nausea and vomiting in the delayed nausea and vomiting traditional period, 120 hours, and then in the extended period, continuing the observation till 144 hours. And again, the NEPA works better than aprepitant and ondansetron in the early phase, and importantly, even in the later phase, giving us a clear idea of the way this drug may work well for those kind of delayed nausea we're observing in ADC patients. See, in this extended overall observation, there is almost 19% of the absolute difference in between the 2 compounds. So it has a more active antiemetic activity compared to aprepitant. And again, if you look at the IV preparation, actually, fosnetupitant is also better than fosaprepitant, having kind of the same delta with regards of extended overall side effects. And in this trial, which is a Japanese trial, the observation period goes as far as 168 hours. So we have kind of solid data about what happens after the very first 4 days after the infusion. So basically, it looks like there is another study, which is patients receiving anthracycline, which actually look at the entire period of CINV control from day 6 to day 21. And it looks like patients get a good response at the very beginning, and they get the right antiemetic prophylaxis. They're more likely to not get any longer nausea and vomiting through all the cycles of the treatment, compared to patients that don't get complete response and continue to have problems. And this slide actually summarizes what I'm saying. You have patients that actually don't get a complete response from nausea from the very first cycle, actually continue to go well through different cycles, and differently from those that don't get complete response, that continue to do poorly through the cycle. So actually, optimal management from the very beginning, trying to get rid of nausea from the very beginning, may be helpful to ensure a course of treatment that is free of these side effects. So basically summarizing NEP activity and rationale why it may be a drug helpful in the ADC emesis control is a better regimen than aprepitant in multiple studies. It has an activity that goes well in the delayed phase and even more than the delayed phase. This may be due to longer half-life, a higher saturation of the receptors. And importantly, NEPA may be used oral and IV drug, and is very easy to use. It's very manageable and don't require further administration later on the days after infusion. Now, this is a new trial. We're just starting to use ADC. So we're actually, in literature, the experience about how to manage nausea and vomiting with these compounds is actually growing. This is a Japanese trial performed in patients receiving a TDXT first line, where they tried a doublet with aprepitant or fosaprepitant with granisetron and dexamethasone. So the triplet versus the doublet, the granisetron and dexamethasone. We're talking about patients, probably these were the very early patients that were treated in the clinic. So really the impact of nausea in these patients were not well known by physicians, and that's why the doublet was taken in consideration. This is the description of patient population, and importantly, many of them experienced nausea in the early cycles and had morning sickness to begin with. Well, the triplet was more effective in control of nausea from the very beginning, and also in control the nausea that was delayed. So using the triplet with the NK and the 5-H3 antagonists and corticosteroids was optimal in all phases for nausea control, in the extended overall phase and in the acute phase. And the total control was favoring the use of the triplet compared to the doublet. Of course, we do have this study includes very few patients, 19 and 21. So it's a hint of the way antiemetic drugs should be used, but needs more confirmatory results. Here are the curves of the proportion of patients in complete response with the triplet and with the doublet treatment. There is a statistically significant difference. So the authors of the paper conclude that we should use an NK1 receptor antagonist together with the HT3 receptor antagonist and corticosteroids, because in ADC treated patients, actually this triplet performs much better than the doublets, and further studies should be done in order to kind of overlook whether olanzapine should be added or not to this regimen for these patients. And this is another study that is actually ongoing, where they're testing the use of olanzapine in this patient population. But what do the guidelines actually say about these drugs? These are the three antibody drug related that we use in breast cancer. The TDM1 is considered by ASCO, ESMO, and NCCN low hematogenic potential. So there is no disagreement among the guidelines. For the TDXT, actually the ESMO guidelines consider them moderate hematogenic, as well as the ASCO guidelines, where for NCCN they're considered high hematogenic. And for sacituzumab govitecan, we have kind of the same picture for the ESMO, moderate hematogenic, and highly hematogenic for NCCN. These are the way moderate, low, or high hematogenic are considered. See, high hematogenic for ESMO and MESH is the risk in nearly all patients, so more than 90% of patients, moderate for 30 to 90%, and low for 10 to 30%. And actually, there is a caveat in the guidelines on the ESMO guidelines, where they do consider these drugs, the sacituzumab govitecan and trastuzumab deruxtecan, moderate hematogenic. However, they do assimilate these drugs to the carboplatin therapy with IUC more equal to 5. And in this kind of setting, actually, the triplet, so the NK inhibitor, the HT3 antagonist receptor inhibitor, and the dexamethasone is advised. So basically, it is considered on the high spectrum of the moderate hematogenic drugs. So we should consider in that way. And these are what the ESMO guidelines suggest for the low minimal emetic agents. So basically just the 5-HT3 receptor antagonist or dopamine receptor antagonist. And this is what is advised in the moderate hematogenic risk, and especially in patients getting carboplatin AUC more equal 5, which are assimilated to patients getting sacituzumab or trastuzumab deruxtecan. In this setting, the 5-HT3 receptor antagonist is advised together with dexamethasone, together with the NK1 receptor antagonist. So you have the triplet, which is advised, and there is no delayed prophylaxis needed in this setting other than aprepitant if you're using aprepitant as an NK1 receptor antagonist. For NCCN, which is the American guideline, most used guidelines, basically the sacituzumab govitecan and T-DXd are considered at high hematogenic risk. Actually, though the frequency of emesis is not as high as 90%, the way of management of emesis is the same that you would use for high hematogenic drugs. So that's why probably they were classified directly into highly hematogenic class. And this is the option for NCCN should be used for when you're doing trastuzumab deruxtecan or sacituzumab govitecan. You should use dexamethasone. The preferred regimen is dexamethasone, olanzapine, 5-HT3 receptor antagonist, and NK1 receptor antagonist. And you should also actually use dexamethasone or olanzapine in the day after the very first infusion. Or less preferred options are dexamethasone, olanzapine, and palonsetron, or dexamethasone, 5-HT3 receptor antagonist, and NK1 receptor antagonist. This would be the option C, would be the suggested preferred treatment for ESMO guidelines in patients getting T-DXd or SG. And they also kind of suggest dexamethasone for the further days and aprepitant if you're using aprepitant on day of infusion day. And of course, we don't need to talk about the treatment of low hematogenic agents because it's very simple and it hasn't changed so far. What can we use as breakthrough nausea and vomiting? Actually, if you manage well the day one infusion using the right regimen from the very beginning, you don't need really to worry about the breakthrough nausea. We basically don't see breakthrough nausea in any patient treated with anthracyclines anymore because we do a right management from the very beginning. And we are starting to get this approach also for the SG and T-DXd patient population. However, if you do have patients experience nausea and vomiting through the whole cycle of your therapy, then olanzapine is sure enough a good option, or cannabinoids or other compounds such corticosteroids or 5-HT3 receptor antagonist or haloperidol, metoclopramide, scopolamine, which in my opinion have a lower range of manageability because they may have other side effects. And how you decrease the incidence of anticipatory nausea? The very first step is to get the right treatment in the right at the very first cycle. In that way, patient never experience nausea and vomiting and don't get the remembrance of this experience, which is actually very much related to the further experiences in the later phases of the treatment. That also you may have hypnosis, relaxation, cognitive distraction, yoga. These are all ways that may help for anticipatory nausea. Those studies are kind of conflicting and usually not very well run, so it's not probably level 1 yet of evidence for this. And the lorazepam may be another compound that may decrease the level of anticipatory nausea. So basically, in summary, we need to have patients getting ADCs, and the ADCs we are discussing is sacituzumab, trastuzumab deruxtecan, and actually need to be assimilated to patients getting high hematogenic chemotherapy, which is carboplatin and these anthracyclines. And this is probably according to all guidelines, because as I told you, ESMO guidelines don't classify them like a high hematogenic, but give these two compounds the same type of treatment you give to carboplatin. So basically the treatment doesn't really change according to classification. The triplet would be a good prophylaxis, and so you need to have an NK1 receptor antagonist dexamethasone, and a 5-HT3 receptor antagonist, and eventually add olanzapine or other compounds in cases needed. And in order, you need to address immediately this type of side effects, especially when you're treating about TDXT. TDXT has probably an increased delayed nausea compared to sacituzumab deruxtecan, and it's probably due to the payload. And we need to remember that nausea with deruxtecan may last longer than 4 days, and sure enough, also longer than 10 days. So we need to have something to kind of cover the patients through all the period and eventually give some breakthrough antiemetic drugs when you have breakthrough episodes. We don't know whether a second dose of Akyncio may work, but obviously we need to have a little bit more, we need to build up more evidence of how one single dose of Akyncio works, because in our experience, Akyncio worked pretty well in ADC treated patients, so we probably don't need a second dose as they're probably evaluating. This is an Italian clinical trial where 53 patients treated with TDXT were started with an NK1 inhibitor on the first cycle compared to an 5-HT3 only treatment. All get dexamethasone to begin with. And as you can see, there is a much lower incidence of grade 2 nausea events, and there is no grade 3 at all. And vomiting is also totally absent when you use an NK1 inhibitor. And importantly, if we don't use an NK1 inhibitor on cycle 1 and you put it on cycle 2, you get an improvement at that point. So it really works anytime you add it on the top of your antiemetic therapy, the drug seems to work. Same thing about vomiting. And now let's move on the clinical case. This is a case we've been starting using the TDXT very early in clinical trials, and importantly in the expanded access, in the European expanded access we had open in our center. So this is a 55, at the very beginning, we really weren't very much paying a lot of attention in nausea and vomiting, because usually in our clinic, we don't see any more patients complaining of nausea and vomiting, as we treat all of them with NK1 inhibitor to begin with. Like if they do anthracyclines, we do use NEPA to almost every patient, or aprepitant. So we don't have any more experience of those. So when we start to use the TDXT, we were really not prepared to treat nausea and vomiting in these patients, though we saw the adverse events incidence in the clinic. So this has the metastatic bone and nodes sites. It was a stage 3, previously treated with several lines of anti-HER2 treatment. She was started to the TDXT expanded access. And we started with the doublet. We started with the 5-HT3 receptor antagonist and dexamethasone and aprepitant. We also put NK1. And on day 2-3, we gave aprepitant as post-medication. However, the patients come back after cycle 1, had a CNV grade 2 immediately after TDXT, and it lasted for longer time with the grade 1. We treated with dexamethasone and 5-HT3 receptor antagonist, but didn't get an important improvement, as the patients were still complaining about feeling a little bit sick, and she didn't want to keep on treatment, because these patients actually are a little bit spoiled, because they're coming from therapies such as trastuzumab, pertuzumab, which actually are completely free of any side effects. So when she started to get the emesis and nausea, and she understood that she may have had it all the times, she was complaining she didn't want a kind of life with this quality of life, because she was used to feel really well. So on cycle 2, we increased our treatment in putting olanzapine on board, but still would not be able to get rid completely of the side effects, as she felt a little bit better, but she still get the feeling of nausea. So on the 3rd cycle, we started the NEPA, and we put together with dexamethasone, and we kept the dexamethasone on board for the day after, and the metoclopramide, and we gave her prescription for olanzapine as a breakthrough medication, and she get finally better, and we didn't need any olanzapine as a breakthrough nausea anymore. and she continued through all their cycles without getting the complaint anymore. So we kind of get this type of therapy became after that our new standard. So we are actually doing netupitant and dexamethasone, and we don't do olanzapine routinely, but we use it as a breakthrough if needed, or for patients experiencing nausea despite this regimen to begin with. And this is just a reminder of overall incidence of nausea and vomiting, which we have been discussing. And these slides just stress the importance of also stratify patients for risk factors, anxiety, history of emesis in other treatment, or motion sickness, morning sickness when they were pregnant, young age. They're all maybe the risk factors for nausea and vomiting development. So if those are kind of individualized, then it may be needed to kind of start with the best treatment we can and don't try to use it later on, because we actually cause not useful discomfort through time. And of course, we do have homemade tips in order to teach our patients to get rid of nausea and vomiting or to avoid it. And these are common sense kind of advices, like eating small meals, sit upright and don't get to the bed immediately after eating, drink plenty of water, get a kind of nutritional advices to seek for type of food that may decrease nausea to begin with, and then help yourself with some alternative treatments, which I told you about, which may be helpful at a certain point. And same thing more or less for vomiting. And for vomiting, I think that the most important thing is educate the patients about how dangerous these side effects may be, especially when you have grade 2/grade 3 vomiting because of the dehydration, and actually educate family members, if the patient is older, and caregivers to pay attention to this problem and try to seek medical advice and help immediately in order to not get the patient fluid depletion and eventually death for these side effects. And this is the end of my presentation. Thank you.
Thank you so much. That was excellent. I think we have some time for a couple of questions. And I can just tell you, Dr. Arpino, so in Ontario, like many of the provinces in Canada, a lot of our anti-emetic guidelines are set forth by the provincial agencies. So CCO, I just double checked, has put Trodelvy, so SG, as moderate. And TDXD is highly emetogenic. So we have the same guidelines for the triple therapy for the HEC regimens and dual therapy for the moderate. And I think most of our patients are getting the aprepitant ondansetron combination. Kenzio is expensive here, and with a lot of the drug plans do not cover it, but it's definitely an option. And we do use olanzapine for breakthrough. So it's nice to hear that, you know, that's your experience as well. Yeah. Are there any questions in the room to start? Okay, I'll check online. You can raise your hand, or let me see, there's some in the chat. Just stop sharing here. Anything in the chat? And what has been your experience, Dr. Arpino, for breakthrough? I tend to find personally that olanzapine isn't a favorite drug for some of our patients. And then we kind of flip to the prokinetics. I actually learned a lot from your talk about extending the steroid. That's not something we typically think of. What's sort of your preference for breakthrough patients?
Well, we do, I think breakthrough is very difficult to treat. Olanzapine is not well accepted from patients, especially because they read the label and the different indications of the drug. And so they come back saying, why you gave it to me? And they try to not take it as much as they can. So they may be vomiting and not take the drug. So I totally agree. It may be effective like haloperidol, but still, it's very difficult to digest. So our approach is to get we can use NEPA because for economically it's actually allowed in our clinic. In Italy, it's kind of jeopardized. Some hospitals do get it on the promontory, others not yet for economical reasons, but we find it very kind of cost effective. So we do use it all the time. And thank God we don't have a lot of breakthrough episodes because I think those are very difficult to treat. And when it happens, either olanzapine, we give the prescription. If the patient is very reluctant, then corticosteroids, prokinetics, or 5-HT3 antagonists are the drugs we commonly use. Though I don't think they're super effective. Our experience is when you get a breakthrough episode, the nausea becomes very difficult to treat because then it's getting worse and worse in the different, because also in our opinion is the experience of nausea that make it worse in the subsequent. It's something you kind of record and remember forever during your treatment. And that's the reason why we try to be as radical as possible to avoid them. Yeah.